Hello, everyone. My name is David Morton. I'm a professor of neurobiology from the University of Utah School of Medicine. And the topic today is the heart, the organ that will pump you up. A lame title, but I hope the talk is good. So to begin, let's talk about Leonardo da Vinci. Most people know Leonardo da Vinci because he painted this painting, one of the most recognizable images in the world. Also did a lot with regards to inventing. He invented this war machine that people have tried to recreate, and flying machines that people have tried to recreate throughout the ages. I just mentioned this because he's known as an artist, he's known as an inventor, but he was also one of the greatest anatomists of all time. No one knew about it because he wrote all of his notes in these notebooks, and many of them we didn't find until centuries after he had died. So during his lifetime, he was in the Santa Maria Nuova Hospital in Florence, in Italy. He was sitting beside a gentleman who turned to him and said, "I'm 100 years old, and I feel great." And they got talking. And then something interesting happened. Without any movement or sign of any mishap, he passed from this life. And I dissected him to see the cause of so sweet a death. So this man that was 100 years old, that now throughout the literature is called the centurion, or El Vecchio, the old one, that Da Vinci brought this individual to the basement of the hospital, and then through process of dissection drew and illustrated. That was one of the things that was neat about Da Vinci, is he was ambidextrous, so he would be dissecting with one hand and he could draw in the other hand. And the anatomy, the anatomical figures he did were so good, I could use his pictures today to teach medical students. One of the things he did was he also dissected the heart. This illustration of his dissection is actually not a human heart. This is probably a sheep heart, but he illustrated, and he was always dissecting to try to figure out purpose or functionality. How about that? And so Da Vinci illustrated and described in his writing, and as you know, his writing was interesting. He always wrote backwards in all of his notes. He described the four-chambered heart and how the two chambers at the top, what we now know as atria, receive blood, and the two chambers below the ventricles pumped blood. He also, in his writing in these notebooks, described how when the left ventricle contracts, the radial artery, the artery here in your wrist by the radial bone, I did that. I was showing this like as if it's like a pulse. He demonstrated when the left ventricle contracts, you feel a pulse in that radial artery. He was so close. He almost described the circulatory system. He was so close. But I kind of imagine Leonardo da Vinci kind of be like, I'm almost on this artery, squirrel. And then he was off to a different thing, drawing, sculpting, inventing, whatever it was. He also, so much of his writings that, especially in the anatomy, we didn't know to the extent of how great of an anatomist he was until centuries after he died. Now, 100 years later, or in the next century, William Harvey is the one credited for discovering the circulatory system. And by that, what we mean is blood goes from the heart to tissues of the body and then back to the heart, and that blood circulates. And so what do we mean by circulatory system? Let's look at this illustration. I drew this in graduate school. It's not the best drawing in the world, but it'll show what I want to do. There, we see on the right side of the heart, I show blood, it's blue. And the reason why I show blue, whenever you see this in some type of a health profession illustration, blue demonstrates blood that is deoxygenated. Most of the oxygen has already diffused to the tissues, and carbon dioxide is now in this blood. And so one of the things the heart has to do is send blood to the lungs. So the pulmonary arteries, the word pulmonary means lungs, or think lungs, and arteries is describing a vessel that takes blood away from the heart, and it goes to the lungs, into the pulmonary capillaries. And this is where gas exchange occurs. This is where carbon dioxide goes into the lungs, and you exhale it, and the oxygen you inhale enters the blood, and that returns to the heart via the pulmonary veins. A vein is a vessel that brings blood back to the heart. So this oxygenated blood enters the left side of the heart, and now you'll recognize how this blood is pink or red. That is showing that it is rich in oxygen. The left side of the heart pumps the blood to systemic arteries that go through all the body from head to toe, and then you go to these cells. And these capillaries are these very small vessels where gas and nutrient exchange occurs with the tissues, and then oxygen goes to the cells, carbon dioxide comes to the tissues, and now the blood exiting the tissues is now deoxygenated. And these are the veins. And the veins bring this deoxygenated blood right back to the very beginning, a very good place to start. So what role does the heart play in the circulatory system? The heart is what pumps blood to and from the tissues. It's the pump of the circulatory system. I've just shown two types of circulatory system. Blood that is coming from the heart and going to the lungs and coming back to the heart, and the blood circulating between the heart and the lungs is called the pulmonary circulation. I've also shown how blood goes from the heart to the tissues of the body and back to the heart. So blood circulating to the systemic tissues of the body, and that's why this is called the systemic circulation. And the coronary circulation I'll talk about in a minute. So let's talk about the heart. The heart is roughly the size of a fist. Weighs about 300 grams, beats between 60 and 80 times per minute. 60 to 100 is considered normal or typical or healthy for most individuals at rest. At rest, if heart is beating below 60, we call that bradycardia. If the heart at rest is pumping above 100, we call that tachycardia. But 60 to 100 is typical and normal. And the heart pumps 5 to 6 liters of blood throughout the body continually. And the heart starts pumping on day 21 after a conception. So when a sperm and egg come together and you have conception, and 21 days later, a primitive heart tube has started pumping, and it will continue to pump until we die. Surrounding the heart, there is a sac filled with fluid that's called the pericardial sac, and it's filled with pericardial fluid, and it looks like that. And so the purpose of the pericardial sac is to help prevent overfilling, because this sac is made of a thick protein called collagen. And the collagen is knitted together to make this very tough sac, and collagen by ratio is even stronger than steel, but to help prevent the heart from overfilling. Also, deep to this pericardial sac in the heart, there's this space filled with fluid. And so the purpose of the fluid is if you do this with your hands, you build up friction between that. Friction in the body, I say it's never good. There's probably an example where it is good, but rarely is friction good in the body, because where there's friction, you get scar tissue that builds up, and scar tissue then makes it so things cannot move that well. And so the pericardial fluid allows it for the heart to pump, 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 and rub up against adjacent tissues, but not build up scar tissue. Here is a photograph of a cadaveric heart. So this is a human heart that has been dissected. The pericardial sac is removed, and all the extra connective tissue is what it looks like. Now this next section, so here is the right atrium of the heart, and then this front part, there's the right ventricle. This is the LAD, called the left anterior descending artery. This is the left ventricle of the heart with the apex. And then this is the pulmonary trunk, and there's our aortic arch coming off. It's beautiful. Now, this next step dissection shows we've removed the front of the heart to be able to show the inside of the right atrium, and all of these things are called pectinate muscles because it looks like someone combed it, where that word comes from. And then down here is the right ventricle, and then there is a papillary muscle with the chordae tendineae and the tricuspid valve, and blood would come up through the pulmonary trunk and pulmonary arteries and go to the lungs, come back to the pulmonary veins, and then the left atrium, you can only see this tiny bit because the left atrium is on the back of the heart. And then here's the open left ventricle with papillary muscles and chordae tendineae going to the mitral valve, and then blood pumps from the left ventricle deep to this and comes out the aortic arch and then goes to the tissues of the body. And so each of these are just showing the beginning of smaller arteries coming off. So there's the brachiocephalic trunk and left common carotid and left subclavian arteries that are carrying oxygenated blood to tissues of the body. This list is the structures that I'm going to cover: vessels, chambers, valves. But instead of using this picture, I'm going to use this illustration because it'll be a little bit more simplified to be able to show. So let's get started. First is the right atrium. It's an atrium. It receives blood. It's on the right side of the heart. And the right atrium has blue blood in it, which means this is shown. It's not really blue in the body, but in this illustration is. is receiving deoxygenated blood, blood rich in carbon dioxide, poor in oxygen. And there are 3 different vessels that bring blood to this right atrium. But I emphasize that no matter what vein, I'll start again. Every vein in the entire body will deliver blood eventually to the right atrium. Now, you only see 3 veins, but every single vein will be a tributary to one of these 3. So the superior vena cava, the one that's entering the top of the right atrium, this is taking blood from every tissue of the body above your diaphragm, where your lungs attach. So every vein, so whether it's intercostal veins in your ribs or radial, ulnar, and brachial veins, or the cephalic and median cubital veins in your arm, or any of the jugular veins in the neck, or the dural venous sinuses in the head, or the facial vein, all of those are tributaries that will deliver deoxygenated blood to the superior vena cava, to the right atrium. And so in a case of heart failure, when the heart is not pumping the way that it should, then what happens is blood backs up. And so one of the ways that you can see how healthy the right side of the heart is how distended or not distended the internal jugular vein is in the neck. And so if you turn your head, you've got this muscle here called the sternocleidomastoid. It's the shing muscle that turns. You have these 2 bellies called the sternal and the cleidal bellies, or the sternum and the clavicle bellies. And between them is where that you can see the internal jugular vein. And so they'll call it a jugular venous pulse. If you can see blood pulsing up in that area when the right atrium contracts, and the higher you see that pulsation or that column of blood, the more severe the possibility that the heart is in heart failure on the right side. The inferior vena cava is now the one, this is the major vein coming into the bottom of the right atrium. It's what's bringing blood from every vein in the body below the diaphragm. And so thinking like your renal veins and adrenal veins, and think of all the veins coming from your intestines, your femoral and popliteal veins and iliac veins, all of that blood, those are tributaries going into the inferior vena cava. And so this is why in the case of right-sided heart failure, there is none of those veins immediately can be seen with the naked eye, but they can be percussed. So if people with right-sided heart failure, blood backs up in the right atrium, that inferior vena cava is bringing blood right from the liver, so the liver may swell on that side, or the spleen may get bigger on the left, and both of those can be touched. Finally, this little hole is called the coronary sinus. It's what's taking blood from the heart muscle itself. So remember how I talked about the pulmonary circulation, blood going from the heart to the lungs and back, and the systemic circulation, blood going from the heart to the tissues of the body and back to the heart. Well, the coronary circulation is blood goes from the heart, back to the heart. Now, what I mean by that is oxygenated blood in the left ventricle comes up the aorta, but then has these coronary arteries that supply the heart muscle called myocardium, and then deoxygenated blood from that goes through the cardiac veins and coronary sinus and delivers the deoxygenated blood back to the right atrium. And the purpose of the right atrium? The right atrium is to take deoxygenated blood, move it through the tricuspid valve, and then enter the right ventricle. So the tricuspid valve gets its name because it has 3 cusps. That superior illustration of the heart with the atria removed, you can see the tricuspid valve with 1, 2, 3 cusps. Its purpose is that when the right atrial pressure is greater than the right ventricular pressure, blood moves into the right ventricle, opening those valves. But when the right ventricle starts squeezing and contracting, and pressure now in the right ventricle is greater than the pressure in the right atrium, these AV valves slam shut and close. So this deoxygenated blood from the right ventricle pumps through the pulmonary valve into the pulmonary trunk, into the pulmonary arteries. And remember, arteries take blood away from the heart. This deoxygenated blood is going to go to the lungs to get oxygenated. So in this illustration at the top, pulmonary arteries are going out to each lung. Gas exchange occurs. We exhale the carbon dioxide. We've inhaled oxygen. And now the pulmonary veins are bringing that oxygen-rich blood back to the heart, and it goes to the collecting chamber. What do we call that receiving or collecting chamber? An atrium. So the pulmonary veins dump into that left atrium, and recognize that the blood is pink in this illustration. It's oxygen rich, carbon dioxide poor. So the oxygen-rich blood will now move through the left atrium through this bicuspid valve, because it has two cusps, also known as the mitral valve because it looks like a mitre, a bishop mitre hat, also called the left atrioventricular valve because it's between the atrium and the ventricle on the left side, or the left AV valve. I know. That's one of the frustrating things of teaching anatomy in medicine is to say this one structure has like 4 names. I'm sorry. I didn't start the fire. Isn't that the Billy Joel song? All right, so here we have a superior view of the heart, and that yellow arrow is showing the bicuspid valve, and it's called bicuspid, bi like a bicycle with 2 wheels, but this has 2 cusps. And but it's also called the mitral valve. I like this photograph because it's showing a close-up that shows the papillary muscle. This is a projection of the heart muscle or the myocardium, which then is attached to the chordae tendineae. These are the heartstrings. So in poetry, when you talk about tugging at my heartstrings, there's an actually anatomical structure. These are the heartstrings that then attach, I meant to put a label there, to this AV valve. So in this case, it's probably the bicuspid valve. The purpose of which is to prevent these valves from prolapsing when the ventricles contract. The picture on the right is showing blood in the left atrium moving through the bicuspid valve to get into the left ventricle. And so that's what's shown here. Blood in the left atrium goes down these open valves to go into the left ventricle. And then what happens is when the left ventricle contracts, the blood is pushed up and slams those valves shut like that. And it makes a sound. We call that the first heart sound, or just to abbreviate, S1. You might also know it as the lub for lub-dub, in the way the heart pumps. So whenever you hear lub-dub, or in a horror film, it's like dum-dum, dum-dum, dum-dum. That's the sound that the heart is making is not the contraction of the heart, it's the closing of these valves. So the S1 is the closing of the tricuspid and bicuspid valve. And then the blood, when the ventricle contracts, it pushes up and on this valve. And so one of the best descriptions I've heard of the structure of the AV valves, Elder Nelson gave a talk in the 80s at BYU, and he talked about how the AV valves are like a parachute and how you've got the very top of the parachute and the strings that come down, and air pushes up and it causes them to dome up. That's what blood does during systole when the ventricles contract and force blood up, causing the valves to kind of dome up like that. Okay, so blood in that left ventricle receives oxygenated blood from the left atrium and pumps the blood through the aortic valve into the aorta. Here we have this cross-section of a cadaveric heart, a human heart, that shows there is the right ventricle and there is the left ventricle. Now look at the thickness of the wall of the right ventricle compared to the left ventricle. The myocardium, the heart muscle, is much thicker on the left than the right. Now why is that the case? So let's just think back of what these chambers do. The right ventricle, this one right here, its purpose is to pump blood from the right ventricle through the pulmonary arteries to the lungs. So blood goes from here to there. That's it. And so there's not a lot of blood vessels, so there's not a lot of resistance that the right ventricle is forcing blood into. And so maybe blood pressure gets from like 10 to 15 millimeters of mercury pressure, maybe 20 on the high end, but not a lot. Now let's think of the left ventricle. So the left ventricle is pumping blood through the aortic valve into the aorta. You now need to go through the vessels to the head, top of your head to the bottom of your foot. So there's so much branching that occurs that there is enormous resistance that this fluid is now moving through. And so the left ventricle must generate enough force to open this aortic valve to force blood into the aorta. That's why the left ventricle is so much thicker. It must generate a much greater force in order to open that aortic valve. And so most people know your blood pressure is like, hey, I just went to the doctor, my blood pressure is 120/80. Great. What does that mean? That means though the 80 means that the pressure inside systemic arteries is 80 millimeters of mercury pressure is pushing against the wall of the arteries. The 120 is the pressure in the arteries after the left ventricle forces a bolus of blood into the aorta, which then squeezes that blood throughout all the systemic tissues. And so the 120/80 describes the pressure when your heart is contracting, 120 over the pressure of your heart over the pressure in the arteries when the heart is relaxing, the 80. So another way that we think of this in medicine is you hear these two terms, systole and diastole. Systole is when the ventricles contract. Diastole is when the ventricles relax. And so to figure out systolic blood pressure, 120, over diastolic blood pressure, 80, is that the heart must generate over 80 millimeters of mercury pressure in order to eject blood into the aorta. And that's the importance of the systolic and diastolic blood pressure. Also, this aortic valve that's shown here in the yellow circle, notice that coming off the right and left cusp are those coronary arteries. The right coronary and the left coronary artery is what's bringing oxygenated blood to all the myocardium and the nutrients to supply them. This picture is showing the left ventricle pumping blood through the aortic valve into the aorta. So here's the left ventricle pumping blood through the aortic valve into the aorta. But then when the pressure in the aorta is greater than the pressure that is in the left ventricle, the blood backs up and slams these valves shut, and it makes a sound, S2, the second heart sound, or the dub. Lub dub, S1, S2, S1, S2, S1, S2 is the sound that are made. Now, the aorta is the largest artery in the body. So if you do this like an OK sign, that's about the diameter of the aorta. And its middle layer, called the tunica media, is half smooth muscle. Smooth muscle is a type of contractile muscle that we do not have conscious control over. It will constrict or dilate based upon the autonomic nervous system, our fight or flight response, sympathetic and parasympathetic nervous system. So one of the things that the sympathetic nervous system will do with many arteries, not all, but most, is it causes them to squeeze, causes that smooth muscle to constrict. And that's what, I'll talk about that later, increases our blood pressure. But when the left ventricle pumps blood into the aorta, it stretches. The aorta stretches. So that's why the other 50% of the wall is elastic tissue, which it comes back to its normal shape. Think of an elastic band. You stretch it and let go, boom, it goes back to its regular shape. When the forced blood during systole into the aorta and expands, elastic tissue brings it back. And it's that squeezing that then forces blood through these thousands of miles of medium, small arteries, arterioles into the capillaries. So the coronary arteries are the arteries that supply the heart muscle itself. They're called coronary because right along the crown of the heart, where you see that, that's the crown of the heart. And so they call them coronary because the arteries course in this area just like the area you'd put a crown. And so what happens now is if you see that X that I'm putting, if you block a coronary artery, ironically, and I say ironically because many organs in the body that they're important have more than one artery that goes to this organ. So if one artery is blocked, the other artery can compensate. The stomach has it, our pancreas or duodenum, or part of our large intestine have it, and even the brain has it, but the heart does not have a sufficient collateral blood supply. So if there is a plaque that builds up in the lumen and that X represents where that plaque is, notice that the blood now cannot get past that blockage. So this area has ischemic damage. Ischemic means a lack of oxygen, which then causes damage to the heart muscle itself. That's what we call if someone says they had a coronary, or they had a heart attack, or they had a myocardial infarction that we abbreviate MI. All those describe the same things, and that is you've blocked an artery and the tissue distal to it cannot get oxygen. Now, what causes that? So that's like, think of a lifestyle of eating fatty foods and smoking and not exercising and add a genetic component to that, all of which can cause this. So you sometimes hear, hey, I just saw so-and-so on the golf course and they died of a heart attack. It just happened. So if it's through atherosclerotic plaque, I kind of butchered that one, didn't I? Let me start again. Atherosclerotic plaque, it just doesn't happen. That is occurring. So it's like that happened over 15, 20, 30 years of smoking, eating fatty foods and fast foods and junk food and not having vegetables and not exercising and smoking, having predisposition genetically, all of which can cause heart disease, or this coronary artery disease is what I meant to say. So what do you do if a patient, they have this, that often it presents as angina or chest pain? And so it refers often in the chest and in the left upper arm is the way it's manifest of that there is a problem with the heart. So they do what's called a coronary arterial bypass graft, or a cabbage is often what it's called. And so what happens is you either do it through a systemic vein or the internal thoracic artery. So this blue vessel here coming off, there's the ascending aorta, aortic arch, and descending aorta. Off the ascending aorta, they take a vein from the lower limb called the great saphenous vein. That's why the vessel is blue. And so in this case of using a systemic vein, there's two operations that occur. One, where they're grafting a vein from the lower limb, and then because veins have valves, they turn it around and they attach one end to the aorta and the other end distal to the block. So here's the right coronary artery. That black dot is representing an atherosclerotic plaque, which means in this individual, when blood is trying to get to the right side of the heart, it's blocked. The road is out. So we then create a bypass. Blood now comes up. We graft in the vein onto the ascending aorta, and the other end of the vein we graft distal to the occlusion. So now blood can come up, down this graft, and then perfuse the blood vessels themselves. That's showing. If you do it to one artery, they call it, single or double or triple bypass surgery. This is showing one. But now here's the other side. So this is a double bypass. The internal thoracic artery, it comes off the subclavian. So there's the brachiocephalic trunk, internal carotid, and left subclavian artery. This is called the internal thoracic artery or internal mammary artery. And so what they do is they take it off the inside of the chest, and instead of supplying the intercostal spaces, they take it and then connect it to distal to where the occlusion is, so blood can come up the left subclavian, down the internal thoracic, and then bypass the clog and get into the heart muscle. This is the coronary arterial bypass graft. So I wanted to just tell a little story about President Spencer W. Kimball and Dr. Russell M. Nelson. What happened is in 1964, then Elder Spencer W. Kimball and Elder LeGrand Richards came to extend a call to Dr. Russell M. Nelson to serve as the stake president in Salt Lake City. And during their conversation, Dr. Nelson had mentioned that he's been having problems that the surgery to replace a faulty aortic valve, often a stenotic valve, has not been having good outcomes in high patient mortality. A lot of patients are dying from the surgery, and he's trying to find a better way of doing it. So when President Kimball blessed him, he blessed that when he served as a stake president, that Dr. Nelson would be able to serve well in that capacity, and he would have great success in overcoming the problems he's facing in doing heart surgery. Now, fast forward 8 years into 1972, they call in Dr. Nelson because Spencer W. Kimball is having heart problems, and he has a faulty aortic valve and he has an occlusion in the left anterior descending artery, and they need to do 2 surgeries. And so they gave a blessing to Dr. Nelson to do this surgery. And I just find it's one of those beautiful things to see in life, the way God puts people together, is that the blessing that President Kimball gave Dr. Nelson 8 years earlier came to fruition. For those 8 years, Dr. Nelson was getting better and better, and he replaced Spencer W. Kimball's valve and did a bypass graft on an LAD. President Kimball was in his 70s at the time, very risky surgeries, and Dr. Nelson said that he was guided through the whole thing and successfully performed that operation. And we then had, the next year, called as a prophet, President Spencer W. Kimball served for another decade in the church. So coming back now, how does the heart pump? Now, the heart's got a couple of things that are really cool, that are unique to it in contrast to other organs in the body. The heart has sympathetic and parasympathetic nerves that go to it. Sympathetics increase heart rate and contractility. Parasympathetics slow down the heart. But the heart has its own pacemaker. It's called the SA node or sinoatrial node, and it's represented by number 1 in this illustration. And there's a group of cells about half the size of a penny, right at the back of the right atrium by the entering of the superior vena cava. And these cells automatically fire action potentials that set the pace of the heart. And that action potential spreads around, think of it like a current, spreads around the atria, and it ends in number 2, which is showing the AV node, which then sends the action potential to the ventricles to contract. And so in heart transplants, when a heart is removed from a patient, and to do that, you've got to cut all the vessels. You've got to cut the superior and inferior vena cava, cut the pulmonary trunk, cut the aorta, cut the pulmonary veins, and remove the heart. So you also have to cut away all those autonomic nerves. And then you put the donor heart in, and they reconnect the vena cava and the pulmonary trunk and the aorta and the pulmonary veins, but they don't reconnect the nerves. Why? Because the SA node fires on its own and will continue to fire. Now, if you need to speed up the heart, the adrenal gland through adrenaline, that epinephrine, can do that. But it's interesting because the heart will pace itself until it doesn't. And that's when you have what are called arrhythmias. Now, arrhythmias is a collective term which means that the current going through the heart is not going the way that it should, or the pacemaker is not functioning the way that it should. So you may have heard someone getting a pacemaker. A pacemaker is now a battery with an electrical device that is placed just deep to the skin by the pectoralis major, and wires go through the subclavian vein to the superior vena cava. And now at the very end, we are going to set the pace of the heart. There are a number of different types of pacemakers. This one shows these 2 cables, one that goes to the SA node, another one goes to the ventricle. So it dually paces. So it causes the atria to contract and the ventricles contract, and atria to contract and the ventricles contract. So what happens is if the heart is not, that pacemaker is not doing the way it's supposed to, and the heart is not pumping, if your heart doesn't pump regularly, that means oxygen and nutrients are not getting to the tissues. That's not good. So this external pacemaker helps to pace the heart for this patient. And it's neat. I work in an anatomy lab, and part of what I do for a living is people who donate themselves to their bodies to medicine. So you know, in your driver's license, often you put in like, hey, I want to be an organ or a tissue donor, or I want to donate my corneas. That's wonderful. It's an altruistic thing. There is another element, and that is you donate your entire body to medicine. And so medical students and dental students and PA, PT students, they dissect in the anatomy lab. That's how they get to know the human body. And so each year we have 30 or 40 donors that we as professors and students dissect to learn anatomy. And every year it's interesting to be doing dissection and then finding a pacemaker in this donor, where you can see this battery pack that's it's about the size of like a large silver dollar, large or just a silver dollar, deep to the skin, and then you follow those cables into the heart to know when that donor was alive, that heart, his or her heart, was being paced by this pacemaker. So now after the heart pumps blood, it goes into arteries. And what are arteries? Arteries are vessels that take blood away from the heart. This illustration is showing the interstates. If we're in the United States, the interstates, the large freeways. It's not showing the smaller roads or side roads or streets or driveways. This is showing the big roads. And so these arteries that come off the aorta either come off the aortic arch and go to the head and neck and the upper limb, or they come down the aorta and go to the abdomen or the pelvis or the lower limbs. And so when we talk about blood pressure, it's the pressure in the arteries. So as I mentioned, the 120/80, it's the systolic blood pressure when the heart is pumping, or the diastolic blood pressure when the heart is at rest. Now, where do you feel those? Is where you have a pulse. And by pulse is that when you're exercising, you feel the carotid artery right here. Thump, thump, thump. The carotid artery is the major artery going to the brain, especially the front of the brain. There's our carotids. That word carotid means to faint, because if you block both of those arteries, it doesn't take very long until you have a lack of oxygen to the brain and the person will faint. But you also feel a pulse, the radial pulse right here, just below the thumb, or the ulnar pulse right here below the pinky, or the brachial pulse that's often used for infants right there between your biceps and triceps. You can also feel the femoral pulse, which is right in the groin. Or the next time you're running and you do some anaerobic exercises and you're like, just look at your tummy and you're going to see your belly pulsing. That's the abdominal aorta. All of those are showing pulses. It's one of the many ways that we can measure how the heart rate. A pulse gives us our heart rate. So if then you take, and I feel this radial artery, and I'm sitting there going 1, and I count for say 10 seconds, and I measure in 10 seconds 7 pulses. 1, 2, 3, 4, 5, 6, 7. And I did it in 10 seconds. Well, I take that 7 and then I multiply it, and that'll help give me, multiply by 10. And it'll give you an idea of what your pulse rate is. Oh, my pulse is 72 beats per minute. Now, a baroreceptor. Baro, like a barometer, measures pressure. And a receptor, I'm just actually doing the math in my head. I think I messed up that math. And now I can't even remember what I said. So if I messed up that math, I'm sorry. Sometimes my brain gets ahead of my mouth. Okay, almost always does my brain get ahead of my mouth. You get the point. You measure the pulse, you can measure where your heart rate is. Now the baroreceptors, there's a few places in the body, the major baroreceptors are in your carotid artery. And what these measure is a change in blood pressure. So have you ever had this where you're, say, sitting down and you're at a desk or you're lying down and you stand up and you're like, whoa, and you get a little lightheaded and you said, oh, I had a head rush. And after 4 or 5 seconds, you're like, I'm fine, and you keep walking? What that is showing that you get an idea, you probably you're a little dehydrated, most likely at that point. But a baroreceptor measures changes in blood pressure. And often when you stand up and the blood pools in your lower limbs, blood pressure to the brain drops. The baroreceptor measures, hey, blood pressure dropped. We need to increase heart rate and we need to increase blood pressure so you don't faint. It's one of the many cool mechanisms that we have in the body to help make sure that our blood pressure stays constant. Now, what is an aneurysm? As I'd mentioned, that arteries have this middle layer, the tunica media, that's made of smooth muscle. When you have a fluid flow of blood, it does not cause a lot of turbulence on the side of wall of the artery. But where you have a lot of, basically it's non-laminar flow, where blood is moving in a very irregular fashion, it pushes up on the side of the wall and causes a weakening in the tunica media. And you have what's called an aneurysm, which is this ballooning out or potential shearing of the layers of the artery. And it looks kind of like a balloon. And so, for example, in all the arteries in the brain, they're called berry aneurysms because they look like a little berry. And you might have heard people say that an aneurysm is like a ticking time bomb, because an aneurysm in and of itself, if it's not pushing on a nerve or something, you don't even know it, that it's there, and it's not causing any problems. But it's called the ticking time bomb because if that aneurysm, as it gets bigger and bigger and the pressure wall gets less and less, and then it bursts, that's why it's a ticking time bomb, because now you have blood bleeding into tissues. In the case of the brain, that's one of the things that can cause a stroke. Another thing that can cause a stroke is that instead of bursting, you get a blood clot that goes and stops oxygen from getting to the brain, either of which are very detrimental to health in the body. Aneurysms, they find really cool ways of using wire technology to fix them, or strokes, putting people on an anticoagulant to stop these blood clots from forming and going to the brain. So once the arteries get down to the capillaries, each of those yellow circles represents a cell. And you put a group of cells together, that's a tissue. So this is where gas and nutrient exchange occurs. So the red blood, the arterial blood carrying oxygen, has oxygen diffuse into the tissues. Now what happens in the cells, you might remember from biology class that the mitochondria is the powerhouse of the cell. You ever heard that? So the mitochondria in all of our body cells, what mitochondria do is they take glucose and they take oxygen. So where does the glucose come from? That's what we ingested in food. So the food that we ate, that's what's coming from the sandwich that you had for lunch. That was weird. The glucose is coming in the systemic arteries as well as oxygen, both of which go to the cells. Then the cells in the mitochondria take the glucose and take the oxygen, and they spit out two things. They spit out ATP, the energy source that we use to power the cells, and CO2, carbon dioxide. Those 6 carbons from the glucose, this is where it's going to give rise to carbon dioxide. So the blood that's now exiting at the other end is rich in carbon dioxide and also some other wastes that come from the cells, and they go in the veins and go back to the heart. So the capillaries is where the gas and nutrient exchange occurs. This is why when you think of systemic blood pressure of like 120/80 and the capillaries, it's like 5. Or it's very, very low. And the blood cells are going in single file. So red blood cells like 8 micrometers diameter, that's how wide the capillaries are. Now, what's pushing the blood through? It's powered by the heart. That's what's forcing it, is the heart pumping and then the blood going into the aorta and then out to all the arteries and percolates into these tissues. And then we also have things called Starling's forces, which is the hydraulic force pushing fluid into the tissues. But then we also have proteins that have an oncotic force that pulls fluids. And so there's this balance between having proteins in the blood like albumin that suck and hold blood into the blood vessels, and a pushing fluid that's generated by the heart, pushing fluid into the tissues. It is the balance between these Starling's forces, named after the scientists who named them, that help us to understand how blood and fluid moves into the tissues and comes back. Now, veins are the vessels that bring blood back to the heart. And one of the differences between veins and arteries is veins are a very low pressured system. We're talking 5 to 10 millimeters of mercury, very, very low. And because they're low, veins often have valves as well, we'll talk about. So they're a very low pressure system. And as a result, when you have low pressure and blood doesn't move very fast, blood forms clots. So if you cut yourself and you got a cut and you're like, oh, it's cut, and you put a Band-Aid on, and then you take the Band-Aid off, even minutes later, you're not bleeding anymore. Because as the blood stops and as blood is pooling in this area where the cut is, it automatically starts to clot. That's good. We want that to happen. The problem is if you've got stationary or stagnant blood because you've got blood that's pooling, like think of sitting on an airplane for a 12-hour flight and you're not moving a lot, blood is pooling in your lower limbs, and when that happens, the blood might start forming a clot. So this is why it's important to wiggle your toes, because by wiggling your toes, your muscles are squeezing those veins. That's actually one of the main ways that we get blood from our lower part of our body to the heart, is we start moving our legs. Where you wiggle your toes. When you do that, the muscles contract, squeezing the vessels, the veins, forcing blood back to the heart. So a varicose vein is where you've got an area where these valves, that our veins have valves that are unique because arteries do not have valves, to help make sure blood flows in a certain way. A varicose vein is when you have a problem with the valves and blood pools. So here we have just a schematic, and the arrow is showing blood moving. So let's say that your gastrocnemius muscle contracts and it pumps blood through this valve, and then blood can go back and close those valves. So that way blood is moving up from valve to valve as we go. A varicose vein is where you get a malformation of this area and the wall of the vessel bulges out, and you get these areas where blood accumulates around these varicose veins. So a take-home point for this is to take care of your heart. And what I mean by taking care of your heart is to do things to help so when that heart, from the day you're born until the day we die, we take care of it. American Heart Association counsels each one of us to do 30 to 60 minutes of moderate to rigorous exercise 5 days a week. It's even shown that if you do 2 days a week and you add up those hours together, if you only exercise 2 or 3 days a week, but you do it for 2 or 3 hours, that is the same that is the same of doing 30 to 60 minutes 5 days a week. I mention that, so if you're the type that I don't have time to exercise every day, but I could on Saturdays and I can on Wednesdays, any is better than none. And I'll tell you something I heard from a sports medicine doc the other day, and it resonated with me a lot. And she said, sitting is the new smoking. Now, what she meant by that is what the literature is showing is that pretty much anyone knows that if you smoke, it increases your chance of cardiovascular disease. Smoking causes atherosclerotic plaques to build up. It increases blood pressure, increases chances of stroke and clots. What we found is sitting, and also that even if you, so those who smoke, if you exercise, even if you exercise and you smoke, your mortality rate decreases, which means if you smoke but don't exercise, your mortality rate is here. If you smoke and exercise, your mortality rate is here. If you stop smoking and you exercise, your mortality rate is here. So what happens, they found, is even if you exercise and you smoke, you still have an increase in mortality. Sitting is the new smoking, which means even if, and this is the thing that scared me, I'm like, what's my job? I'm like, I sit so much at my desk, eh? So think of the number of us that sit at our desk and you're like, hey, but I go on a moderate walk every morning for 20 minutes or 30 minutes, and you sit 8 hours a day, it still reduces, your mortality rate still goes up, and you still have a higher risk of cardiovascular disease. So the key to this is why, on these smart watches, how it says, hey, good job, you stood up. It's important that at least every hour we get up and stand up and you walk around, you get the blood circulating, do something to maybe take stairs in your building to help get your heart pumping a little bit better. So this is now wherever I go, I take stairs. No matter where it is, escalators, elevators, I take stairs because it's one of those many ways throughout the day. In addition to me working out between 6 and 7 a.m., Monday through Saturday, I take stairs where I go. You take care of our health, our heart. We eat well. We lots of vegetables, green leafy vegetables. Avoid junk food. So take care of your heart. I think that's one of the take-home messages. This is a miraculous organ that each of us has. I wish you all the best, and it's a pleasure having a chance to talk to you about the heart. Thank you.